Well, over the years, my laboratory has been interested in biomarkers for ovarian cancer. In the 1980s, we had developed the first monoclonal antibodies against ovarian cancer cell lines. And one of those, the 125th, recognized a mucin that was eventually characterized as MUC16 that led to the CA-125 blood test that's used worldwide to monitor patients with known ovarian cancer. This is also used to detect disease recurrence and also as part of a panel of tumor antigens that can be used to distinguish benign from malignant pelvic masses. If a patient is thought to have a malignant pelvic mass, to trigger referral to a specialized gynecologic oncologist with special experience in doing large operations required to remove cancers. But we're also have been very much interested in whether CA-125 could be used to detect early stage disease, because early detection test for ovarian cancer really has not yet been developed. It's a real unmet need. And if disease is spread throughout the abdomen or above the diaphragm and elsewhere, less than 20% of patients can be cured. If you can detect ovarian cancer when it's in the ovary itself, hasn't spread, or even in the pelvis, about 2/3 of patients can be cured with currently available treatment with surgery and combination chemotherapy. Consequently, if you could detect more early stage disease, you could reduce mortality from ovarian cancer by 10 to 30%, according to computer simulations. There have been several large trials of CA-125 alone. One very large trial in the UK, the UK CTOX, failed to show a survival advantage, although it's not clear that all the patients received up-to-date treatments. This was done about 20 years ago. And consequently, not all the patients received combination chemotherapy as part of their regimen. We've used the same strategy in a study that's extended over 2 decades, where we had looked at rising CA-125 to detect patients who benefit from ultrasound. And based on the ultrasound exam, whether they looked like they had cancer. And with that, we had studied 7,800 women, over 50,000 women years of observation and screening, and performed 34 operations. And with that, we detected 17 ovarian cancers and borderline tumors. And with that, there was more than a 74% sensitivity, and 70% of the patients we did detect were in stage 1 or stage 2, potentially curable disease. This was not randomized against people who weren't screened, so we're not sure whether that would have improved survival or not, but it did suggest that we might be headed in the right direction. But if we're going to do that, we knew that we missed at least 30% of the cases with using just CA-125 alone. And so we've looked at more than 130 biomarkers for ovarian cancer to see what would detect CA-125 negative early stage cases. And we found in that article that you mentioned that there were 3 other biomarkers, HE4 antigen antibody complexes, and also osteopontin. And with those, we could detect 13% more cases than we could with CA-125 alone. And so we've now developed with Steve Skates and Jacob Bedia a second-generation algorithm to determine how much of a change in those 4 biomarkers is enough to prompt ultrasound and eventual surgery. And with that, we've just started a trial last September using the 4 biomarkers to determine what the specificity was, to be sure we're not going to see too many false positives in individuals who are screened with the 4 biomarkers instead of just CA-125 alone. Certainly, exploring autoantibodies that patients make against their own cancer-associated proteins, or antigen antibody complexes where those autoantibodies complex with shed antigen, is really a work in progress for several different cancers. And we're collaborating with a group at the University of Houston to look at additional antigen autoantibody complexes that may even be more effective than the HE4 antigen autoantibody complex that we're currently studying. But it's certainly another area where there's a need for biomarkers, whether they're antigens or autoantibodies or complexes, is in pancreatic cancer, where again we don't have an effective screening. There are a number of groups nationally and internationally who are working in that as well. Well, there's been a lot of good work in metastasis research in ovarian cancer. One of the characteristic places that ovarian cancers metastasize is from the ovary or the fallopian tube to the omentum, which is, of course, a fatty apron that extends over the bowel. And one of the targets that we've studied over the years is called salt-induced kinase 2. This was really discovered with one of our postdoctoral fellows, Ahmed, who's now a professor of gynecologic oncology at Oxford. And he had screened a number of kinases to see what could be knocked down to enhance in cancer cells, to enhance their sensitivity to Taxol. Turns out that one of those targets was salt-induced kinase 2. And subsequently, people have developed chemical inhibitors of salt-induced kinase 2 as drugs. And when you use those, you can enhance not only the sensitivity of ovarian cancer cells to Taxol, but also to carboplatin and to PARP inhibitors like olaparib. In addition, we're finding that you can enhance sensitivity by a completely different mechanism to checkpoint inhibition, and that's in immunotherapy. And that's, of course, been a real challenge in ovarian cancer, which is usually not as responsive as melanomas or renal cell cancers or many other tumors for which checkpoint inhibitors have been prescribed. From a perspective of metastases, Ahmed did some very important work independently in which he published in Cancer Cell in 2016, where he showed that salt-induced kinase 2 was overexpressed in the metastases in the fatty acid and lipid-rich, adipocyte-rich omentum. That they were higher there than they were in the primary ovarian tumor. He also showed that the adipocytes would stimulate phosphorylation and activation of salt-induced kinase 2, and in turn, salt-induced kinase 2 would turn on several of the enzymes that were required for fatty acid synthesis. And so it looked like there was a real role for salt-induced kinase 2 in metastases in ovarian cancer that tend to be adipocyte-seeking. We currently are in the middle of a clinical trial of an inhibitor of salt-induced kinase 2 called GRN300. That's currently on pause, seeking additional funding. But so far, the drug has very little toxicity, and we've been able to achieve levels comparable to those that we use in the laboratory to potentiate drugs like Taxol and carboplatin and PARP inhibitors, all the three drugs that are most frequently used to treat patients with ovarian cancer. Well, clearly there is more work to be done in developing early detection tests. Certainly one of those is to use multiple protein and immune biomarkers, as I described in our own efforts. There's a great deal of interest, understandably, in using DNA or methylated DNA as a biomarker, not only for ovarian cancer, but for multiple cancers, with the hope that you might be able to use the same blood test to detect multiple cancers earlier. And currently we're collaborating with groups that are using methylated DNA to see if we can add the protein biomarkers like the ones we're using or others that we've discovered in collaboration with a group in Toronto to add to the DNA tests, because if we could put together the power of and versatility perhaps of DNA with the specificity of some of the protein markers, we might be able to have both a more sensitive and ideally more specific test. Certainly. We know one of our challenges is to extend the technology and the extraordinary results that have been achieved over the last 30 or 40 years to patients all over the world. In leukemia, which was, when I was growing up, was in children, which is a death sentence, or was a death sentence. And children would die of acute leukemia within 3 or 4 months of diagnosis. And now in the United States, 90% of children with acute lymphoblastic leukemia are cured. And we're trying to figure out what the most safest, most modest chemotherapy can be so that they don't have defects from that lifelong and are cured and then have full normal lives. There is the challenge of extending that to other parts of the world. And certainly one of the causes that we've supported is treatment for childhood cancer in Egypt. And I think that they clearly are making gains on that, and we need to extend that to all countries. In terms of the Dan Van Hoff Award, I over the years have mentored a number of young physicians, physician scientists, as well as laboratory-based researchers in my own lab. We have programs at MD Anderson for physician scientists who usually have both an MD and a PhD, or an MD with a lot of laboratory experience. And when they join our faculty as assistant professors, they need to get their first grant from our National Cancer Institute. And with that, they really need dedicated time to do their work in the laboratory to get the preliminary data they need to develop additional ideas and to write effective grants. And so we've got a program where they have 80% dedicated time. They still spend 20% working directly with patients. These are all exceptional physicians as well as scientists, and they really enjoy clinical work, and that's why they entered medicine. So they do both. But with that, we've been fortunate enough that 44 people who graduated from our program over the last couple decades, 87% have gotten their first grant. We also have another program that's sponsored by the National Cancer Institute for clinician investigators who are learning how to not only just do one trial at a time, but to develop a program of research to take on a particular kind of cancer or a particular family of drugs. And again, we've had some 34 graduates of that program. And we went back and looked at what happened after they went through the program. And 13 of them had actually been leaders of trials that were approved, that resulted in drug approval by the Food and Drug Administration of a new agent for treating cancer, or had trials that changed the practice guidelines nationally. So these are 13 who actually changed practice of cancer care, not only in the United States, but farther afield. And I think it's really crucial that young people are encouraged to get the education and background that they need, and then given the time and support they need to establish their own careers. Because, over the last 3 decades, we've decreased mortality from cancer in the United States by 1/3. We still need to improve cancer care for the other 2/3. So we're part of the way there, but it's going to be the young physician scientists and scientists who are able to carry that battle forward so that we can eliminate cancer. It's not a question of whether we're going to do that. It's really when. And so that's why it's so important that we develop the careers of young people.